Hello everyone, and welcome to our DeBakey Grand Rounds. It's a pleasure having you today here in the studio, in addition to globally. As you know, this is broadcast through live stream as well as YouTube, and you can also access this through our DeBakey channel on YouTube. Today is a very special day for our Grand Rounds because it is the William Winters Lectureship. This is our 31st lectureship for Dr. Winters, who was really an amazing leader in cardiology. We miss him over the past 4 years as he passed away. But I tell you, I think this is a lesson in leadership in cardiovascular medicine for our younger leaders and our fellows as to what you could aspire for. Leadership in cardiovascular medicine, in addition to any other areas of medicine, is not necessarily by a lot of volume of publishing and discovery. And you can be a leader as a role model in education and how you forward and you push forward the mission of cardiovascular medicine and medicine in general. And this is what Dr. Winters was. He came to Houston in 1968, was really the first to start a non-invasive laboratory, the first echo laboratory in Texas and the South. And that was in the basement of this institution. We graduated up to the 9th floor, but over time. But really, he was a very good friend with Dr. Edler, Dr. Feigenbaum, and he really brought that. And it's not only ultrasound that he was a leader of. He and among two other people brought PCI interventional to this institution. So he was an invasive as well as a non-invasive cardiologist. He was president of the American College of Cardiology. He was the first one who started Houston Cardiology Society. He was president of the American Heart Association for Texas. And he really made his mark in so many ways. And he was a role model for trainees. He was certainly a role model for me as an amazing clinician who cared about patients and knew how to take care of patients. And in addition, he was a writer. So, I think I would encourage you to take a look at a book that he wrote because he was so passionate about, this institution and Houston and cardiovascular medicines. As you know, that was the hub of areas there. He wrote Houston Hearts, and I would definitely encourage you that it is available. So I cannot be here and think about the so many contributions that he has done over his legacy. So we celebrated him during when he was with us, and certainly we celebrate his legacy by bringing amazing individuals in the world that have moved the needle in cardiovascular medicine. So this lectureship has been here for 31 years. The last two are Dr. Brownwald and Dr. Seidman. So this year is also our esteemed lecturer is also from Boston, and he really does not need an introduction, Dr. Peter Libby, who has been the trailblazer and the discoverer in so many areas of atherosclerosis and cardiovascular medicine. He is the Mallinckrodt Professor of Medicine at Harvard University and the Brigham and Women's Hospital. He directed the cardiovascular medicine division at the Brigham for 16 years, from 1998 to 2014. We were talking about it yesterday that many of the leaders that you see nowadays in cardiovascular medicine at the Brigham, actually he brought to the institution, including Dr. Ron Blankstein, Marcello Di Carli, and so many others. And I guess between these two institutions, we have quite a few presidents of cardiovascular societies that I think we have to be very proud of the impact of what we've done. His passion has always been atherosclerosis and the role of inflammation in atherosclerosis, and he was certainly instigator, and helped really lead the large trial, the CANTOS trial that all of us know about IL-1 beta inhibitors, and the role, which has really solidified the role of inflammation in atherosclerosis and outcomes. He's received numerous research awards, including, and I will mention a few, the Distinguished Scientist Award from the American College of Cardiology, the Gold Medal of the European Society of Cardiology, the Basic Research Prize of the American Heart Association, the Annie Stark Prize in Atherosclerosis Research in the European Atherosclerosis Society, and the Ernest Young Gold Medal of Medicine. He's currently, actually, in a few months, he will be receiving the ACC Valentin Fuster Award for Innovation in Science. So congratulations, Dr. Libby. His professional involvement has been numerous and so well recognized and exemplary. Membership include Association of American Physicians, American Society of Clinical Investigation, honorary memberships of the British Atherosclerosis Society and Japan Circulation Society. He served as president of the Association of University of Cardiologists. He has frequently consulted for the NHLBI, directed the D.W. Reynolds Cardiovascular Clinical Research Center, and chaired the Leduc Foundation Awards. He has received continuous funding for several years from the NIH, and he currently serves as president of the International Atherosclerosis Society. He's published, obviously, extensively on the topic, and we would love to hear from his views today about inflammation and atherosclerosis and where's the field going. He's an editor of Braunwald, Heart Disease, and he was the editor-in-chief of the 12th edition of Braunwald. He has delivered more than 150 major named and keynote lectures throughout the world. He earned his medical degree at the University of California, San Diego, completed his training in internal medicine and cardiology at the Peter Brand Brigham, then known by that name, and nowadays is Brigham and Women's Hospital. And he also holds an honorary MA degree from Harvard and 3 honorary doctorates. What a pleasure having you, Dr. Libby, with us today. And it really is an honor to host you and listen to your perspectives on inflammation and atherosclerosis.
Great. So thanks so much. The honor is actually mine. And it is very humbling, first of all, to revisit this medical center, which has been such a hub of innovation and clinical activity for so long, and also to be in this lineage that includes my own mentor, Dr. Braunwald, my colleagues, Dr. Seidman, Pat O'Gara, who was my clinical chief and friend, joined at the hip for 16 years at the Brigham when we ran cardiology there. And it's wonderful to be here. It's also humbling because, you know, they don't make them like this anymore. You know, a master clinician, a bedside teacher, a pioneer in non-invasive imaging and in interventional cardiology. And in addition, this guy was a poet, and he was the historiograph of this medical center. And I've read a little bit about this, and it looks like I'm going to have an opportunity to read it, but apparently at the end of chapters, there are little anecdotes, little special stories with the history of this great medical center and some of the giants that trod its hallways in the past, of whom the current people are, of course, equal. So it's particularly special for me to be back here to do this. These are my competing interests. What this slide says is that I consult broadly, but I do not accept any personal payment from any pharmaceutical or device company, although I do have some options in a couple of startups that will probably always be underwater. So I'm going to talk about inflammation today. I guess last Friday I was in Paris giving the American lecture at the French meeting, and I talked about acute coronary syndromes. But I thought here I would talk about sort of this long trajectory from being in the basic science lab through to large-scale clinical trials to really try to convince people that inflammation was important in atherosclerosis. So everyone has a slide like this, don't you? A slide that shows the initiation of atherosclerosis with our risk factors, such as LDL, causing some kind of havoc in the intima, and then we begin to recruit these unwelcome visitors to the artery wall. The mononuclear phagocytes that are the foot soldiers of the innate immune response, but also T cells, which are perhaps less numerous, but give instruction to the more numerous mononuclear phagocytes and get the inflammatory machine in motion actually early in life. Now, the smooth muscle cells are usually quiescent in the tunica media, the middle layer here. The human intima actually has resident smooth muscle cells, but when they get hot and bothered, then they can migrate and multiply and begin to create some of the fibrous character of the atherosclerotic plaque. Now, we tend to think of atherosclerosis as a lesion that grows inexorably and it progresses. But I've come to appreciate that atherosclerosis is actually, if we look under the hood, there's a tug of war going on constantly within a plaque, within a tree, and within the entire arterial vasculature. So we have a struggle between life and death, between procreation and perishing. We have smooth muscle cells that, as I mentioned, can be fruitful and multiply, but then they can go on to die. And the smooth muscle cells are very important because they make the extracellular matrix, which is the sinew that gives tensile strength to the plaque's fibrous cap. That's all that stands between many of our patients and an acute thrombotic complication of atherosclerosis. The mononuclear phagocytes also can divide within the artery wall, probably earlier in the history of a lesion based on mouse data. And then they can go on and die. And sometimes clearing the dead cells is impaired. That's called defective efferocytosis. And that contributes to the formation of this lipid core, sometimes referred to as a necrotic core. So we've got this struggle between life and death that's going on right now in many in this room, and certainly in many of our patients. Now, these are some of the mediators that cause that tug of war. This is the alphabet soup in which I live. I'm not going to go through all of this. If you'd like to read about it, I refer you to some of the references here. But basically, we have this struggle between pro-atherogenic mediators and those that actually oppose it. So the net balance over years of this internal struggle is what gives us the lesion. And in fact, within a given coronary tree, within a given arterial tree, we have lesions at all phases of evolution where we're in different stages of this pitched battle which is underway. So my view of atherosclerosis is that inflammation is involved not only in the inception of the lesion, but also during the long clinically silent or stable phase of progression and up to and including the thrombotic complications that bring the patients to our attention as clinicians most dramatically. Now, we focused for decades on the so-called vulnerable plaque, the thin-capped fibrous atheroma, and we spent many, many years in my laboratory, several decades, picking apart the cellular and molecular biology of plaque rupture. This slide summarizes a lot of that work. And it tells the story that when we have those T cells in the lesion, that they can secrete a pro-inflammatory cytokine known as interferon gamma that actually puts a brake on the ability of those smooth muscle cells to manufacture new collagen that is required to repair and maintain all important fibrous cap. On the other hand, we studied the production of specialized enzymes that can break down this usually very stable macromolecule, the triple helical collagen molecule, that gives strength to our sinew, to our skin, to our bones. And the story that we told was that the T cell, again, can send messages to the mononuclear phagocyte and turn on the production of these very specialized enzymes that can break down collagen. And we showed that in the human atherosclerotic plaque that those enzymes are increased in places where the cap would be thin and where we would be able to provoke a thrombotic event if there were a rupture. And we also found that some of the same mediators that turn on these collagenases, these interstitial collagenases, can turn on the proximate trigger of thrombosis in the disrupted plaque, and that is tissue factor. So inflammation sort of rules the roost in terms of the determinants of the acute coronary syndromes. Decreased synthesis of collagen, increased breakdown of collagen, and turning on the thrombogenicity of the lipid core that makes it so dangerous for the blood with its coagulation factors to gain access to that innards of the plaque and setting off a thrombus. But in an era of highly effective lipid lowering, plaques that have the thin cap fibrous atheroma morphology are less frequent and cause fewer acute coronary syndromes. And I collaborated with Gerard Pasterkamp in Utrecht, who has a very large collection, the AtherExpress database. And I'm not going to go through the data, but simply to say that if you look at human atherosclerotic plaques retrieved at carotid endarterectomy as a function of time, in the Netherlands, where there's been very good penetration of contemporary lipid-lowering therapy, there's a halving in the number of inflammatory cells and a striking decrease in the lipid content. Yet, I'm sure your coronary care unit is filled with acute coronary syndromes. So what is it that is causing these residual events in an era of extreme lipid lowering and all the other good things that we know how to do now? Well, I have argued that another mechanism is now on the ascendancy and may account for some of the differences in clinical presentation that we witness. Fewer STEMI and more non-STEMI. And that, of course, is superficial erosion, which we've all learned about from people like Rainer Vermani. But actually, if you look at what we've learned from the study of these lesions, those that cause thrombosis due to erosion are quite different in many ways from the classical TICFA. And we spent the last decade or so trying to pick apart the cellular and molecular mechanisms of erosion, as we did previously with plaque rupture. And I'm not going to go into that in great deal, but suffice it to say that after decades of studying the mononuclear phagocyte in the context of rupture, in the context of erosion, we think that the granulocyte is important. Maybe not as the primum movens, not as the first guy there, but once the granulocytes are present and activated, they propagate and amplify the endothelial injury that gives rise to the eroded lesion and thrombosis. So it's wonderful to be able to stretch my brain to encompass another type of leukocyte, which has generally been accorded a second role in atherosclerosis. I've also had a great privilege of working with my former postdoc Phil Swirsky and his research partner Matthias Narendorf in trying to fill out the cardiovascular continuum that Dr. Braunwald formulated with Victor Zhao about 30 years ago. And this is the expanded or revisited cardiovascular continuum, where we include the central nervous system, signaling between the central nervous system and the bone marrow, and stimulating leukocytes, which can then go back to the lesion and push it through one of those phases of growth, because the plaque is very dynamic, and we've been able to pick apart some of the factors that control the generation of leukocytes that can contribute to the mayhem in the plaque. I'm not going to talk today about clonal hematopoiesis, which is actually what my lab is working on now, which also takes us back to the bone marrow. So you can invite me back sometime to hear about CHIP. Okay, so this morning I went on the feeble, not broadband Wi-Fi in my hotel room, and I interrogated Google Scholar. And it took much longer than it does at home with high-speed internet. It took about 0.2 seconds to come up with almost 2 million references for crossing inflammation with atherosclerosis. And if you look at inflammation, immunology in atherosclerosis, over 400,000 in 40 milliseconds. So entire forests have been mowed down to contribute to the literature in this area of inflammation and immunology and atherosclerosis. But a lot of it has to do with mice, a lot of it has to do with tissue culture. So certainly these have been very, very good to me through the years. But really, I practice ambulatory and inpatient cardiology. I'm going to be on starting Monday the 4th on our inpatient service. And to me, the challenge is to take all of the basic science, all of that ferment in the laboratory, and translate it to the people that we care for in our clinical job. So maybe 15 years ago, Christy was present at the birth here, and Christy Valentine also was one of the first people to study chemokines in atherosclerosis. So here I'm preaching to the choir. But I set out to pose this question: can targeted anti-inflammatory therapy improve cardiovascular outcomes? Not in mice, not in rabbits, not in pigs, but in people. Okay? And it's a pretty hard journey. So if you want to get the references that provide the foundation for where we went with the first trial that proves that inflammation is actually important in humans and can be a therapeutic target, I refer you to this paper that was published about the time that the results of the first anti-inflammatory trial came about. And the references are all there, but I just want to take you a little bit down memory lane. Now, I'm obviously going to talk about the future at the end of this talk, but it's instructive to see how you can go from the lab bench through to phase 2, phase 1, and to finally a phase 3 trial. So back in 1980s, the mid-1980s, when people were just characterizing the pro-inflammatory cytokines, we made what was a disruptive observation at the time that was widely disbelieved by the immunologists. Remember, interleukin, what does that mean? It means between white cells, right? And here's Peter saying, hey, wait a minute, intrinsic vascular cells, such as the endothelial cells shown here, or smooth muscle cells, can actually produce these weird and wonderful inflammatory mediators that we were just learning about. So this is interleukin-1 beta messenger RNA. In the resting endothelial cell in culture, no message. For the young people in the audience, this is an antique technique known as northern blotting. This is before PCR, believe it or not. And when you stimulate the cells with a pro-inflammatory stimulus, such as bacterial lipopolysaccharide, gram-negative endotoxin, we were readily able to induce the messenger RNA for L1 beta, also in the original paper, alpha, its cousin. We also showed the biological activity in the protein was made when we stimulated these cells. Now, when we did these experiments, we thought that bacterial endotoxin was a laboratory artifice. But I wanted to test this hypothesis with a tactical nuclear weapon. So we exposed the cells to endotoxin. But now, with our increased appreciation of the microbiome and of impaired epithelial barrier function in certain diseases, including HIV/AIDS, maybe LPS is much more relevant, biologically relevant, than we thought back in the 1980s. Well, we were on a roll then, and we very soon, the next year, found that IL-1 can induce its own gene expression, setting up an amplification loop, this auto-induction. We did it in vascular cells, endothelial cells shown here, smooth muscle cells as well, and with Charles DiNarello, who actually is the hero of the interleukin-1 story, we did it in vivo in rabbits and in human mononuclear phagocytes there in the 1980s. Well, we then went on and found that interleukin-1 can induce another pro-inflammatory cytokine, interleukin-6. This is a log-log plot. And look at, you get huge amounts of interleukin-6 pouring out of cells such as vascular smooth muscle cells, but this works in many kinds of cells, including endothelial cells. And we see that a little bit of IL-1 will beget huge amounts, picograms per cell, of interleukin-6, this other pro-inflammatory cytokine. And I'll remind you why we were interested in interleukin-6 already in the late 1980s. Well, interleukin-1 beta like many mediators that are critical in biology, is first synthesized as an inactive precursor and requires a limited proteolytic cleavage in order to attain its activity. Think of the complement system. Think of coagulation. You know, factor 10, factor 10A, okay? Requires proteolysis. And the protease that affects that cleavage to activate the precursor of IL-1 is known as interleukin-1 beta converting enzyme, or ICE, but now it's regarded the founding member of the caspase family, caspase-1. And back in 1995, we co-localized that enzyme in foam cells in human atherosclerotic plaques. And in the biochemistry laboratory, we showed that when we stimulated human vascular smooth muscle cells or endothelial cells with a pro-inflammatory mediator that we already knew was operating in human atherosclerosis, CD154 or CD40 ligand, that we were able to coax the processing of this inactive precursor to the active form of IL-1, that this was dependent on the interleukin-1 beta converting enzyme, and that it co-migrated with standard and authentic IL-1 beta. So actually what we discovered then in the late 80s was a biochemical pathway. What we didn't discover was the inflammasome, which is the instigator of the activity of caspase-1. That was done by Jörg Schulp, and we'll see that in a moment. And it looks to me like I'm running out of battery here, so we'll move over to the laser here. We've got a pathway here where we have the pro-inflammatory risk factors, whatever they may be, and that induces IL-1, which can induce its own gene expression, a first amplification loop, and then there's that log-log amplification of this whole pathway by production of IL-6. Why was I interested in IL-6 back in the 80s? Because we already knew that it was the chief instigator of what we call the acute phase response in the hepatocyte. And let me remind you about year 2 in medical school. The acute phase response tells the hepatocyte, okay, take some of your substrate and energy, and we don't need a lot of housekeeping proteins now because we're in an emergency state. Make a little less albumin, but let's pump out things we need to respond to danger, such as fibrinogen, the precursor of blood clots, because when we're bit by the saber-toothed tiger, we don't want to bleed out. And also plasminogen activator inhibitor 1, PI1, which is the major inhibitor of our own endogenous fibrinolytic system. So it's a perfect storm when you have the acute phase response. We have more substrates for coagulation and inhibition of fibrinolysis. Very important for host defenses, right? And wound staunching bleeding, but can be turned against us in the context of atherothrombosis. So we were working with IL-1 beta since it was first characterized in collaboration with Charles Dinarello. And I had the opportunity, and I told some of the backstory last night at dinner with a glass of very nice Hermitage wine. And we were able to convince Novartis that a drug which they were marketing for orphan indications, diseases of genetic overactivity of the inflammasome, could be used to quell inflammation in atherosclerosis. So I'm very grateful that Novartis listened to me and that we were able to get this study off the ground. And this is the design paper for the CANTOS trial. And we targeted inflammation with a monoclonal antibody that neutralizes IL-1 beta. And Christy, you will remember, I think we were somewhere north of Miami, Ventura or something, when we had critical meetings because we had to actually add a dose to the study after the study began because the FDA wanted a no effect dose. We disappointed them in that regard. So what you can see here is the 3 doses of the antibody had a nice lowering of C-reactive protein measured with a high sensitivity assay, our index, our biomarker of inflammation, but no changes in atherogenic lipoproteins. So we knew that the statins, which can both have lipid-lowering independent anti-inflammatory effects and lower lipids, when we did statistical games, we could show that maybe half of the benefit of statins in certain circumstances was due to an anti-inflammatory effect, independent of LDL lowering, but you could never rigorously deconvolute inflammation from lipid lowering with the statins, and here we did that. So we had a very clean experiment to test the inflammation hypothesis. This is the top-line result of the CANTOS trial. I've heard this described as a modest effect. Well, it's 15%, which is exactly numerically what was seen in Odyssey outcomes and in Fourier with the PCSK9 inhibitors. So if this is a modest effect, so are the effects on LDL in statin-treated patients with PCSK9 antibodies. And in a pre-specified analysis that Paul Ritker, who was the PI of this trial, and I helped him lead it after instigating it with my contacts at Novartis. This is a pre-specified analysis that looked at the people who responded to the canakinumab by dropping their C-reactive protein more than median. And what you see here in the green bars is a greater than 30% drop in cardiovascular mortality and in all-cause mortality in the people who responded well to the intervention. This is the holy grail of all clinical trials. Patients had less inflammatory complaints. They got much better from the point of view of their arthritides. We published separately in the Annals of Internal Medicine the gout outcomes, which there was a drop of about 50% in gout. Gout is an inflammatory disease that is driven by the NLRP3 inflammasome, which is at the apex of this pathway. But we paid a price, that there was inhibition of some of our host defenses. There was, in a 10,000 plus person study with a median exposure of 3.7 years, a statistically significant but very small increase in infection and some fatal infections due to sepsis. Now, we learned in this study who's at risk and what the infections are. They were not weird and wonderful opportunistic infections at all. They were just standard pyogenic infections, bacterial infections, and viral infections. So I think what we learned from CANTOS would allow us to mitigate a lot of the infectious risk, and it's something that I think we're going to be learning how to do. But I want to return now to interleukin-6. So here's our pathway again. Here's the inflammasome at the apex, and the purple there is the business end of the inflammasome, which is caspase-1, which activates pro-IL-1 beta and its cousin IL-18 to the active forms. Then there's this first amplification loop that we discussed, a second amplification loop, and the acute phase response. Okay? So the question is, because IL-6 is downstream of IL-1, could we preserve IL-1 beta's role in host defenses, but diminish cardiovascular risk by targeting interleukin-6? So let's look at the evidence, both observational epi and genetic evidence that inculpates interleukin-6 in atherothrombosis in humans. This is ground zero. Paul, when he was a young investigator, showed back almost a quarter century ago that your level of IL-6 independently predicts cardiovascular risk. He showed this in physicians' health and then in women's health. And this has been widely reproduced. This is emerging risk factors collaboration, hazard ratio of all coronary heart disease, non-fatal MI or coronary heart disease as a function of your IL-6. And here's Paul's initial study. This is in women's health. And you see in this forest plot how the observational epi really lines up to show that there's a strong association between interleukin-6 and prospective cardiovascular events. But of course, these associations don't show causality. And that's why we're fortunate to have some variants, common variants in interleukin-6 signaling. And 40% of the people in this audience have a variant that gives you diminished function of interleukin-6. And if you look in a gene dosage dependent way at two of these variants that limit interleukin-6 signaling, you see that there is a stepwise reduction, a gene dosage dependent reduction in C-reactive protein shown in the open squares and in odds ratio of coronary heart disease shown in the filled squares with two different variants that are hypomorphic for IL-6 function. So yes, we have observational epi, but we have concordant and very strong human genetic evidence for causality of interleukin-6. And by the way, if you do this with IL-1, it doesn't work. Okay? So maybe the reason that IL-1 was a good target was because it blocked the production of IL-6 through the acute phase response. So I have to do a little bit of a detour to set the stage for the next couple of studies I'm going to talk about. And that's a patient population which is very vexing for us. When we're on the consult service, we see patients who are on dialysis, we see patients with chronic kidney disease. They die of our disease, right? And you know, one of the only places where statins don't seem to work so well in reducing events is in chronic kidney disease, advanced kidney disease. For example, in the 4D study or in Aurora, so a little frustrating. So this is a really crying unmet medical need to decrease cardiovascular risk in the patients with CKD. A huge population, and each one of you in the room who practices faces this on virtually a daily basis. I think when I'm on inpatient service, the median eGFR is probably about 45 in my inpatient service. So we took a look in CANTOS at what drives those results in a population where statins don't seem to really be able to make as much headway is in people without statins. Now, please don't stop your statins in your CKD patients because of this. But so what we did is we looked at the bulk of the patients in CANTOS who had okay renal function, about 8,000, and then we looked at the almost 1,100 people who had CKD. And we asked the question, what is driving recurrent events? Remember that these patients were selected for having inflammation, and they were all on highly effective statin therapy. Our baseline LDL in this study, we took great pains to get the LDL really low because we knew the study was going to be widely criticized. And our baseline LDL was about 10 points lower than in Fourier and in Odyssey outcomes. So we had really good statin treatment, and these patients were selected for having some ambient inflammation. And lo and behold, what you can see here is that your C-reactive protein, your index of inflammation, correlates with recurrent events with a hazard ratio of about 1.5. But if we do the same exercise with LDL, it's flat. So it looks like what's driving those events in patients with CKD who are already on statins is more likely to be inflammation than driving their LDL into the sub-basement. So that was part of the background of choosing a population of patients who had chronic kidney disease to do a phase 2 study with an antibody, a monoclonal antibody, that this time targets IL-6, one step distal to IL-1 beta in this pathway that we worked out in the 1980s and early 90s. This was the rescue trial, which was led by Paul Ritker and was a classical kind of dose-ranging study. And what we found was pretty remarkable, was that there was a profound reduction in C-reactive protein in that CKD population. Remember, I showed you this graph and said that there was a substantial decrease? Well, it wasn't profound. It was about 36% in CANTOS with the anti-IL-1 beta antibody. Now, going one step closer to the hepatocyte, by targeting IL-6, we got an over 90% reduction in the index of inflammation in the highest dose that we studied. This effect was stable, and a number of other biomarkers in this phase 2 study were concordantly dropped. So this was the prelude to an ongoing phase 3 study, which is called ZEUS, which is enrolling people with high CRP with stage 3 to 5 chronic kidney disease, and it is over 70% enrolled as we speak. So we're going to have an answer. Why did we target CKD? Well, it's a large unmet need, very high cardiovascular risk, particular biological state, because as I showed you, LDL seems to be less important in driving at least recurrent events than inflammation. And also because colchicine, about which I'll remind you in a moment, is relatively contraindicated in CKD. So where is IL-6 inhibition going? Now that there is a monoclonal antibody that looks safe and certainly effective in its anti-inflammatory effects, well, there is a HFpEF study called Hermes, and there is an ACS trial. We wanted to do CANTOS 2, and so this is sort of non-CANTOS 2, but looking at ACS, called Artemis. Okay? So we're going to get some answers about targeting IL-6 very soon. So beyond cytokines, what are the anti-inflammatories? Well, we're very excited and very heartened to see the results of the colchicine trials, which have come out in the last few years. There's Colcott and Lodoco-2. Colcott looked at people who are fresher post-MI, and Lodoco-2 in people who are in a more chronic phase of CAD post-MI. And there were striking and remarkable decreases in cardiovascular events in both of those trials that were quite well conducted. And that led to the approval in last summer of colchicine with a really broad label for prevention. So we've all become comfortable. Those of us who trained in the days of yore used colchicine for gout. Then there was familial Mediterranean fever. And then we learned to use it for pericarditis, and really were able to forestall a lot of the problems that we had with corticosteroids in pericarditis. But now we have an atherosclerosis indication. This is the first anti-inflammatory drug with a label for atherosclerotic coronary artery disease. So hats off to the investigators of Lodoco-2 and of Colcott. But if you drill down, there's some lingering concerns. You see that there is a signal for pneumonia. The numbers in this trial were lower. And remember, it took us 10,000 people for 3.7 years median exposure to see a statistically significant increase in infection in CANTOS. So let's keep our eyes open for safety in terms of infection. And of course, there's the GI intolerance, which usually gets better and is pretty much manageable. There are also concerns about the mortality signals in some of these studies, including a smaller ACS trial, COPS, where mortality went the wrong way. Now, I can't finish this talk without talking about the incretin mimetics, because your jaws dropped when the press release came out and then the presentation at the AHA of the SELECT trial with semaglutide in patients who are non-diabetic. And this is, I tease my friend Steve Nissen that he did the right thing for the wrong reason when he said to the FDA that we really need to have cardiovascular safety trials for anti-diabetes drugs, because if we hadn't done those safety trials, we wouldn't know that SGLT2 inhibitors are good for heart failure in non-diabetics and all across the ejection fraction spectrum, and we wouldn't know that the GLP-1 receptor agonists and the twincretins, we think, and follow-ons are actually having effects that are beneficial in non-diabetics. So, you all know this, you've all seen this, the SELECT trial with a remarkable reduction in cardiovascular events. But here's my favorite line in this study, is that it looks like there's an anti-inflammatory action. We knew that there was laboratory studies and this and that hint that the incretin mimetics were anti-inflammatory. But here, in this large randomized placebo-controlled trial, we see an almost 40% reduction in C-reactive protein. So we have to add the GLP-1 receptor agonist to the potential anti-inflammatory drugs. So inflammation is a common contributor to atherothrombosis, and it's becoming clinically actionable. Today, you can write a prescription for colchicine for those who meet the entry criteria of the two studies that I mentioned. So where are we in the anti-inflammatory therapy of atherosclerosis? Well, I think that Dr. Winters was a student of history, and he would be familiar with this famous quote from Winston Churchill at a turning point in the Second War. Now, this is not the end, it is not even the beginning of the end, but it is perhaps the end of the beginning. And that's where I think we are today with this translational journey from the laboratory bench through to large-scale clinical trials. And wonderful thing is the ability to work with younger people who are smarter than me. And there are people in my lab and their collaborators. I was talking to Christy about Pradeep Natarajan, who's like this Halley's Comet of brilliance that I'm fortunate to be able to work with, and his team. And Sheikh Katharesan was one of the instigators of some of this work that we've done, and the people in my lab who've contributed to this story through the years. So thank you so much for the honor of being here and sharing this with you.
Peter, that was really amazing, and a tour de force, and congratulations for you, your laboratory, your co-investigators on really making a major dent and improvement in our treatment on understanding atherosclerosis and our treatment beyond statins and diet and exercise and everything else. So this is a new area. As our token for your lectureship, for our William Winters lectureship, we have a small plaque for you dedicated to you and thanking you for your talk today about inflammation and atherosclerosis and translational journey. Thank you very much.
Thank you so much.
I'm not stopping here because I know you went online to take a look at some of, but this is actually, these are two books from Dr. Winters. The one that you quoted, the Houston Hearts, which I would recommend to all of you, and also an anthology of limericks that he wrote, and they're amazing. So I hope you'll enjoy them.
As I started out, I said they don't make them like this anymore. What a polymath, and what a role model, as you said, for people who can be innovators in procedures and in imaging, but also revered bedside clinicians and teachers. And you had my colleague Pat O'Gara here, and Pat, he practices cardiology on a different level. So when we had the postgraduate course, the Brigham postgraduate course, back when we had live meetings, I used to be the person to run around the microphone with the room when he was talking, not because I needed the exercise, but because I learned so much from the master clinicians, still today.
Amazing. Well, let's open it for questions. Please use a microphone.
Well, Peter, thank you for an outstanding lecture. It's always good to learn so many new things. My interest has been more in aortic valve disease and coronary disease, and of course, calcific degeneration shares some of the same risk factors. Are we able to apply the same things to valve disease as we do to coronary artery disease, do you think?
So there are elements that are shared. So my colleague, she was sort of a technician in my lab. Now she's a full professor at Harvard Medical School. Elena Aikawa has really taken this thinking, and she was one of the first to show that inflammation is important in valvular heart disease. We published together about the metalloproteinases in mitral degeneration and myxomatous degeneration of the mitral valve, and she's now made a whole career out of studying aortic stenosis. I think that the really landmark observation comes from the GWAS for aortic stenosis, where there is one skyscraper, which is lipoprotein(a). And so as someone who advises the companies that are developing the siRNA and the antisense oligonucleotide that target Lp(a), we're urging them to do a careful look at aortic valve function, because wouldn't it be great if we had a medical therapy that could forestall the development of aortic stenosis, particularly because we are now, I'm screening everyone for Lp(a) because we're on the threshold of actionability, and it's amazing. If you look, you will find. So, please check your Lp(a) in your preventive patients, because we may have a therapy that we could deploy. It's very genetically determined, so I do cascade screening. That's one of the reasons that I do Lp(a) today in everyone who comes to see me in my practice. And we may be able to take people who are in their 20s and lower their Lp(a) and have a twofer. Okay, this is hypothetical, right? But it's a terrific hypothesis based on strong human genetics that we could lower cardiovascular risk or coronary risk and aortic risk. So you should invite Elena to talk about aortic valve disease sometime.
Would
She
love
doesn't,
that.
she doesn't do clinical work, but she's great in the lab.
Other questions?
That was really masterful. I always learn something when I listen to you speak, Peter. I think without saying it, you gave our fellows and trainees the roadmap for having a successful career. You take an observation that might change the conceptual framework, something interesting, and just keep hammering away at it, keep digging and expanding upon it, and you can ultimately find something that will change our idea of pathophysiology and potentially clinical care. I do have one point about that I think is missing from your beautiful slides of the initiation and progression of atherosclerosis. I think the endothelium should be there, because you can't have vascular inflammation without the complicity of the endothelium. And Mike Gimbroni and Myron Cebulski at your place showed years ago that at Ben's branches and bifurcations, you have an atheroprone endothelium long before you have any monocyte interaction with the endothelium, long before you have any lesions. So maybe comment on that.
Yeah, well, I do believe in the endothelium and showed the adhesion molecules in one of the, I think the first cartoon, and have worked quite a bit on that, and of course collaborated with Myron and Michael. And I agree with you completely, because the regionality, so the point is that the entire arterial tree is bathed in the same LDL, but the lesions tend to form at stereotype place where there's flow disturbance, and we understand some of the molecular signaling that leads to the activation of the endothelial cells, recruitment of those leukocytes, and perhaps increased recruitment of macromolecules or particles such as LDL. So you're absolutely right. And of course the whole superficial erosion story, which I didn't go into, is all about endothelium. And that's where our interest in neutrophil extracellular traps and the neutrophil amplifying and perpetuating the endothelial injury that is the basis of superficial erosion is important. So I agree with you completely about that. And of course, worked cheek by jowl with Michael Gimbroni on the 7th floor of NRB for many years.
Dr. Mary.
Dr. Libby, congratulations. First of all, it must be very gratifying to advocate a concept making the initial basic science discoveries 40 years ago and finally see fruition at the clinical medicine. Congratulations.
Yeah, well, so John was saying that. I was thinking, is this persistence or is it being obstinate?
And both.
Yeah, go ahead.
You must be a very patient person to wait 40 years. I've never seen a person come to that side. My questions to you is, not debating the role of LDL and other atherogenic cholesterol and inflammation, do you think components other than cholesterol contributes to inflammation and atherosclerosis, including DNA damage, senescence of endothelial cells, vascular muscle cell, and some of the effect we see is really targeting senescence inflammation, SAPS, senescence associated cyclotrophic. The second question to you.
Well, let me just,
about
because my memory is feeble, so let me answer that one. So you're right on. So we know that triglyceride-rich lipoprotein particles are probably causal in atherosclerosis, but it is the cholesterol in those particles that actually is probably pro-atherogenic, because they deliver the cholesterol through a different mechanism than the LDL particles. And I agree with you completely about endothelial mesenchymal transition, and agree with you completely about the SAS, the senescence-associated response. And IL-6 is one of the major SASP mediators. So you're completely right. One of the things that I think we need to be clear about is that despite everyone's cartoon starting out with oxidized LDL, and all of the in vitro and experimental literature in animals that inculpates oxidized LDL and atherosclerosis, all of our trials with antioxidants, including the antioxidant vitamins, and a beautiful trial, the ARISE trial with succinylbucol, which is a lipophilic antioxidant that should be right there in the core of the LDL particle preventing its oxidation, have been null. So, my cartoons, everyone else's cartoons have the oxidized LDL, but the data in humans is rather feeble. And that's why I think we've got several shots on goal with inflammation that look more promising than antioxidants. There was a time when, if you talk to Joe Whitstam and Sam Samikas in San Diego, when they couldn't oxidize the LDL from some of these California fruit and veggie people because they were popping vitamin E and they had so many antioxidants in their diet, you couldn't oxidize the LDL. But when you do the clinical trials, they've been null consistently. But I think maybe by targeting IL-6, maybe we'll be combating the senescence-associated response.
Thank you very much for that terrific talk. I wanted to go back to the beginning of your talk when you spoke about how atherosclerosis is important in the development of atherosclerotic plaque. There are some reports on blockade of CD47 that reduces the inhibition of atherosclerosis. I just wanted to see what your thoughts are, both from a basic science and a clinical translation.
Yeah, so Nick Leeper has been one of the leaders in that area. The idea of atherosclerosis was really championed by Aretabus, but I reminded him in our paper about apoptosis that was published in the mid-90s that we talked about mummification of cells because the math didn't work out. The indices of apoptosis that we're getting with terminal end labeling was higher. The lesion should have been atrophying, and so we figured that the cells just weren't getting cleared, and that's what atherosclerosis is. So I pointed that out. So we called it mummification. He calls it defective atherosclerosis. And CD47 is one of the mediators. So Nick Leeper at Stanford, brilliant guy. He has a company that he's founded with Irv Weissman to try and target CD47. Has some very nice publication, including a letter in the New England Journal about CD47. It's the eat me signal. Okay? And if you can restore the phagocytosis and the engulfing of dead cells and clearance, then you may be able to forestall some of that mischief in the lipid core.
Dr. Al-Kindi.
Thank you for the awesome lecture. My question is really, as we move towards personalized medicine, are we using the wrong test, for example, systemic IL-6, plasma IL-6, plasma CRP, to identify the patients who have systemic inflammation, or should we look at a little bit more focal markers of inflammation, pericoronary adipose tissue inflammation, maybe a PET, FDG, things like that, to enrich the benefit for the patients.
Yeah, so that's exactly the direction that we should be going. What's astonishing is that after a quarter century, that no blood biomarker of inflammation has proven better than C-reactive protein for a variety of serendipitous and basic reasons. That CRP is just a great analyte. There's a cheap, reproducible assay with an international standard. It's stable. The Pentraxin structure is quite stable, so you don't have to spin the blood immediately. You don't have to freeze it. It can stay on the bench for a while before you assay it. So CRP is really pretty hardy, but your point is it's not local. And could we, maybe using nanotechnology of the kind that John has worked on and others here, target selectively plaques that are inflamed. And certainly there's a lot of interest. There's interest in the sodium fluoride imaging for calcification from the Edinburgh group. There's interest in the Oxford group in fat attenuation index, or FAI, looking at the perivascular fat in standard garden variety CTs, and a variety of other ways. Now that we're applying artificial intelligence to imaging, we may well be able to point to certain lesions that are inflamed and maybe target local therapy. It's going to have to go against systemic therapy, and also we're not going to be putting people in scanners or giving them radioactive imaging agents as a screening test. So maybe what we'll do is do a first tier of screening with our simple $15 C-reactive protein test, or IL-6, which has now become scalable because our labs learned how to measure during the SARS-CoV-2 pandemic. And then people who have persistently elevated systemic biomarkers, we could then elevate to another tier where we do imaging, but none of the imaging of inflammation, as fun as it is, has actually been used to allocate a therapy showing a benefit. And that includes CAC scores, as I was discussing with the fellows yesterday.
Dr. Nasser.
Dr. Libby, thank you so much for this very inspiring journey, taking a hypothesis, creating the evidence, and truly establishing the pivotal role of inflammation in plaque progression and instability and downstream consequences, and of course the target therapies. Now, as a preventive cardiologist, I want to move the needle a little to the left with initiation and primordial and primary prevention, where now tremendous amount of, I would say, observational prospective studies have suggested that maybe a high systemic inflammatory state, if you don't have atherosclerosis, would have little impact as far as initiation or even outcomes are concerned. So my question to you is it time to recalibrate our story based on whether you have atherosclerosis or not, and maybe look more deeper in those who have not yet developed atherosclerosis to understand whether inflammation would still have the same role?
Mm-hmm. So that's an interesting aspect, is that you think that the inflammation may come after lesion initiation. It's sort of like the reverse causation argument that we're having about clonal hematopoiesis now with my friends and collaborators, Kamila Maxarova, whose lab is 5 stories under mine. So which comes first? Is it the inflammation or the athero? I think that there's a good case that you can make that athero is important in the initiation. Whether it's reflected in a systemic marker of inflammation in the peripheral blood is a matter of question. So how are we going to deal with primordial prevention? Well, as I was telling the fellows yesterday, we need to get physical activity restored to the curriculum in schools. We need to get sugar-sweetened beverages out of the schools. And we need to use our roles as community leaders to try to affect those societal changes, non-pharmacologic lifestyle measures that are toxic to our populace. And then in terms of picking out people for pharmacotherapy or intensive lifestyle intervention, I think that the polygenic risk scores may be important. I use the example of Lp(a) as a single marker that we might be able to pick people out of the population whom we might be able to forestall the development of aortic stenosis, for example. Not during the careers of any of you structural fellows here. Later. It's going to take 30 years to figure that one out. But I think the PGRS could help us pick people out in early years for more intense lifestyle and sometimes pharmacologic therapy. Remember the studies of the Korean War casualties that showed raised lesions in red-blooded American boys raised on Wonder Bread in the 1950s, and those were corroborated by casualty studies, and Renu Vermani did some of these analyses in the Vietnam War. So just because you're 20-something doesn't mean that you haven't got the beginnings of athero and that tug-of-war going on in your arteries, and maybe PGRS could help us pick people out for more advanced, maybe even imaging, that could say, okay, this person, risk-benefit of taking a drug is going to be on the plus side.
Dr. Lowry.
Sure, Roy. Thank you very much, Dr. Libby. That was a great talk. It was particularly enjoyable, the historical span of your survey and the prominence now given to inflammation. I had the privilege of spending a 25-year period with Dr. DeBakey and Tony Goddard during the early days. I have to say Dr. DeBakey was a very strong skeptic of the lipid theory of atherosclerosis, primarily based on the fact that on a daily basis we'd be operating on these arteries. They were clearly severely inflamed, many chronically inflamed. Sometimes it's very difficult to dissect them out. Other times you could actually see the redness and the inflammation in the tissues. And as a result of this, I was asked to do a study of 13,000 of his patients. He did very meticulous follow-up, clinical and angiographic on his patients. And this culminated in a study, and the conclusions of the study were that there were the different arterial beds had a very distinct difference in the incidence of the disease. And the second was that the patients fell into categories of a single episode, which then for many years, with careful follow-up, there was never any gross clinical evidence of further atherosclerosis. An intermediate group that would perhaps be in it every 3 to 5 years with perhaps a carotid and then a femoral popliteal lesion. And then a third group that just year by year, almost, we went through coronary bypass, both carotids, abdominal aneurysm, renal arteries, legs, everything. And I was wondering if there's been any progress, first of all, in terms of further elucidating the anatomical differences in susceptibility, what the basis of that may be. And secondly, whether we really have a good handle on the intermittent relapsing nature of this disease, and what is it exactly that makes someone go from a heart attack and then 10 years of perfect existence to another heart attack.
Yeah, the frequent flyers, yes. So one of the reasons I start out by talking about the dynamic nature of the plaque is because there's this tug of war going on. And in some people, those blue mediators may have the upper hand over the red mediators that are pushing athero, because there's really a yin and yang going on inside of my arteries right now and maybe yours. Okay, so it's a matter of the balance between the pro-resolving and anti-inflammatory factors and the pro-inflammatory, pro-thrombotic factors. With regard to the geographical distribution, we already heard from John about the shear stress, and just recently last year, I think with Peter Stone and Bill Bowden, we published a paper in JAMA Cardiology that went into some of the latest thinking about shear stress and even some of the very local changes within a single plaque when you do the fluid dynamic analyses of shear stresses and athero. But I didn't talk about clonal hematopoiesis, but I can't help myself here, because one of the surveys that was led by Derek Claren, who is now at Stanford, is a brilliant vascular surgeon, suggests that some of the somatic mutations which give rise to these clones of mutant blood cells as we age, which is actually pretty common. So by the time we're 70, we have a 10% chance of having a clone of mutant blood cells that arise from somatic mutations, acquired mutations, not mom and dad, but cosmic radiation and cigarette smoke and stuff. One of those mutations, or one cassette of those mutations, the DNA damage and repair, seem to be particularly associated with peripheral arterial disease. That's the TP53 and PPN1D. So we published that in last year. Derek Claren is the senior author. And that's a hint that there really is a biological difference between PAD and coronary artery disease. We're just in the infancy of being able to understand that, but you're right on. And we see that as non-surgeons, that some people will be quiescent for 20 years and have no recurrent events, and others will be malignant reoccurrers and malignant restenosers. I'm glad that you invoke the observation of surgeons on the actual disease, because you look at it several times a day. And John Manick, when I was directing vascular medicine at the Brigham, we used to have that conference with John, and they would talk about inflammatory aneurysms, which were the ones that had rip-roaring adventitial inflammation. But from my perspective, and having looked at a lot of tissue, which you got actually from that group, from Andy Whittemore, et cetera, I'm talking to John because he worked with us at the Brigham for a while in vascular medicine. I think all aneurysms, at least AAAs, are inflammatory. There's some that may have super responses that you can see with the naked eye. But for me, the AAA tissue that I've looked at in the mid portion of the lesion, there's wall-to-wall destruction of the media and tons of inflammatory cells in the adventitia, and we've implicated some of these elastolytic cathepsins and elastolytic MMPs in that destruction of the media that we don't know what comes first, right? But certainly in the burned out end stage of aneurysms, inflammation is rampant. So thank you for bringing up your observations.
All right. Well, I know it has been an amazing discussion. Cannot thank you enough for an extraordinary lectureship and a great discussion among the group. So thanks very much.
Thank you. We should get one of the fellows to take a picture of us with the plaque.